And we're back again with the Ninja Nerd Podcast. Today we're talking about microcytic anemia. We're actually breaking this one up into 3 different topics because anemia is a monster.
It's just too dang big.
It's just too dang big.
Yeah. So it's definitely going to be easier, I think, and more bite-sized. You won't have to carve out a portion of most of your day to listen to one gargantuous podcast. So it could be a little bit smaller. So we'll do microcytic, and then the next week we'll do normocytic, and then the last week we'll finish off with macrocytic.
So we got a pretty cool trilogy of anemias coming up.
Yeah, exactly.
All right, well then, without further ado, let's start it up with microcytic anemia. We got 4 cases in total, right?
Yep.
4 cases.
Yep.
Try and figure it out as we go along, but we'll break it down as we go. All right, Zach, so based upon these lab findings, I do have a couple of questions, and hopefully you can kind of break that down in a stepwise fashion.
Yeah, let's see.
All right. So question 1, based on the lab findings, what type of morphological anemia are we dealing with and why?
I think that's a great way of posing it. And the reason why is when we think
you wrote the question, so.
I'm giving myself a little pat on the back.
Yeah.
So, yeah, essentially kind of preluding into this is that when you think about anemia, it is a challenge. It's a lot of things at once. And that's why I think if we break it into 3 parts, it makes it easier. Okay. And so the first component of this is microcytic anemia, right? And so that's how we look at things morphologically based upon size. And so the term that we like to look at, particularly from the red blood cell indices or the CBC, as we're getting parts of that here, is you look at the MCV. Okay. So anything that's generally like less than 80 kind of falls into this category of what we would say is kind of microcytosis. Anything that's between 80 to 100 is kind of the normocytic, kind of like normal size red blood cell. And then greater than 100, we fall into that macrocytic. So first thing I need to know is, does the patient have anemia? Because that's what I'm looking for here. And so these values aren't standard across the board. I'd say for every institution or hospital, it can vary. But we like to say less than 13 for a male is considered to be anemia, and then less than 12 for a female is considered to be anemia. So
for the hemoglobin?
Yeah, exactly. So the hemoglobin is 9.5. We're definitely having anemia. The next thing in the algorithm is to say, look at the MCV. Is it less than 80, 80 to 100, or greater than 100? In this case, it's less than 80, so it's going to fall in the microcytic anemia camp. So that's the way I would look at that. Now, once you fall into microcytic anemia, these are the 4 differentials that you have to have, and that's why we have 4 cases. Kind of cool, right? It's going to be iron deficiency anemia. That should be one of your differentials. It's the most common, I'd say, across all the microcytic anemias. Next one is anemia of chronic disease. The third one is sideroblastic anemia, which is relatively rare. And then the last one is going to be thalassemia, which there is 2 types, alpha and beta thalassemia. That's more of a genetic one. You would probably say that would be the least likely, but it's something that we'll talk about as well. So once I've done that, I say, okay, I know that this is microcytic. I have my 4 differentials. What's the next part of my algorithm? Well, it was actually nice that I got most of my iron panel. So when I get microcytic anemia in there, I know you're laughing at the way I said iron. Guys, do you think I say iron weird?
Go, just
move past it?
No. Let's not move past it.
Make some comments in the comment section. Like, do I say iron differently?
Just say it again.
Iron.
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 He's iron.
I just can't do it. I don't know why.
I don't know. Maybe you guys could hear something different.
Please tell me.
I'm pretty sure that I'm hearing iron.
Please tell me. Comment on the comment section. I really want to know.
But for now, we'll definitely move past it because we got some things to learn about here.
Yeah. So if we look here, we look at the iron panel. And so I like to look at the iron level. I like to look at the ferritin. I like to look at the TIBC and the transferrin saturation. And that gives me a lot of information. So first thing I like to look at the algorithm is I say, okay, what is the iron? Is it low or is it normal or high? If I see low, I think about 2 differentials. 1, iron deficiency anemia. 2 is anemia of chronic disease. In this case, my serum iron is low. So I'm down to those 2. Okay. Next thing I look at is the ferritin. Is the ferritin normal? Is it low or is it high? If it's low, that highly suggests more likely to be iron deficiency anemia over the anemia of chronic disease. In this case, it is low. And so if the ferritin is low, the serum iron is low, then what I know right away is this is likely a patient who definitely has iron deficiency anemia. I can kind of confirm that by looking at the transferrin saturation.
And just, I know things change upon institution, but the ferritin, what would be normal?
I would say anything less than 100 is kind of on the lower side.
Oh, wow. Okay.
Yeah,
so this is very low.
Yeah. So 15 is pretty low. So anything less than 100, I would at least say and consider that this is probably one of those kind of lower situations.
Okay.
And then I would look at the transferrin saturation. I like that better than the TIBC. I don't find much benefit of the TIBC, but it can be utilized. Transferrin saturation low, that means that I have less iron bound to transferrin. And so right away, this iron panel suggests that it's iron deficiency anemia over any of the other like three. What I look at next is what's the history telling me. And history, I have to break it down in my head. It's either I'm not absorbing it, and that would be history, kind of like maybe they have a very poor diet, strict vegetarian. This patient is a vegetarian. I don't know if they're like super strict. Another one is malabsorptive syndromes. Do they have a gastrectomy? Do they have a Roux-en-Y gastric bypass? Do they have a history of autoimmune disease? Because you can see that in pernicious anemia. Do they have celiac? Some kind of like bowel resection in the past. And then the next thing is, are they losing it from their body? So blood loss is a pretty common one. If it's chronic blood loss from heavy menses, we would see this a lot. Peptic ulcer disease, like slow bleeding ulcers, or colorectal cancer in anybody big greater than 50. Don't forget that they love to test that on the boards.
So big red flags then for her is a heavy menstrual period, and then she does follow a vegetarian diet.
Yeah, I think that's the likely etiological factors here in combination with the anemia based on the hemoglobin at 9.5. MCV fits in the microcytic camp, and the iron panel in combination with the history more likely suggests iron deficiency anemia in this case. That's what I would go with.
So we know this is a microcytic anemia. What would be the next test to suggest iron deficiency anemia? As you said, it's very common over any other differential.
Yeah, so I would say right at this point, I'm pretty good with saying I feel confident it's iron deficiency anemia. But if you want to add some utility here, I would say go look for the source. So in this patient, she has heavy menstrual periods. The vegetarian diet, I would actually kind of reach out to her and I would say, hey, we need to kind of modify your diet a little bit to maybe less strict and make sure that we're getting enough iron in your diet as needed.
Okay.
But I would want to try to look for the reason that she's developing this, which is the heavy menses. So
right.
I'm worried, is there like fibroids? Is there some type of like weird menstrual kind of abnormality that's causing abnormal uterine bleeding? Endometriosis, fibroids, whatever it may be. Let me go ahead and get a pelvic ultrasound to kind of take a look at that. If it's someone that had like a GI bleed, like they have melena, they have some black tarry stools, I would maybe get like an EGD with a biopsy to look to see if there's any kind of like slow peptic ulcer. If it's kind of like a darker one where I have a brighter red blood per rectum, maybe they're greater than 50, they have some risk factors for colorectal cancer, I may get a colonoscopy. So it's a matter of kind of like figuring out what's the underlying etiology. That's what would be kind of my next test here. And I would say the heavy menses would make me get a pelvic ultrasound to really see what's going on there. And is this something that we can address?
Based on the findings of the iron panel, what would be your next step in the management and treatment of the underlying issue?
Yeah, so it definitely have to treat the underlying cause. So
like you said, some definite diet changes.
Yeah, I would say we have to kind of improve the diet, make sure that she's getting an adequate amount of iron, maybe supplementation of some sort.
Okay.
And I would even kind of go as far as to say to make sure that she's getting enough, because you lose a lot of iron in a day, especially with bleeding. With these patients, they can lose a lot. Mm-hmm. So with these heavy menses, I'm going to try to support the iron intake, and I'll give her oral iron. So I'll probably start her at like 325 milligrams, maybe once or twice a day. Sometimes you can even do it more frequently, but I would do that. And I like to give it with vitamin C because it actually helps to enhance the absorption of the iron. So that's kind of what I would start off with, but I would actually have to treat the underlying cause. What's causing the heavy menses? And if this is something like fibroids or endometriosis, oftentimes like oral contraceptive therapy would be the way to go with that. If it was a peptic ulcer disease, I'd have to treat that accordingly to get rid of the ulcer. If it's due to H. pylori or discontinue their NSAIDs, if it's colorectal cancer, I'd have to treat the cancer. So going forward with all these things, you'd have to treat the underlying cause to prevent recurrence. So that's the most important thing, I think.
With this patient, she obviously has some pretty heavy menstruation. At what point in anemia is a blood transfusion indicated?
Yeah, so she doesn't need one, but I'd say anything less than 7 is usually like our numerical threshold to say at this point we should consider giving like a unit of blood to keep it above 7.
Okay.
But those numbers differ. I think according to Up to Date, we like to say that you can trigger the transfusion threshold. We like to say less than 7 in any kind of patient, but we can make it a little bit higher if there's other kind of problems going on. So if a patient has like coronary artery disease and we know that they have that, like they have plaques that are, maybe they have like already 85% stenosis of their left anterior descending artery, and we have history of that, I probably shouldn't let them drop down too low. So if they get to less than 8, sometimes we'll transfuse them. If they're actually having an acute coronary event, so for example, they're having an active MI, I actually may push it up higher. Sometimes you can push it up above 10. And then I would say any patient, regardless of what their hemoglobin is, if they are hemodynamically stable and I have a high suspicion that they're losing blood, like I'm seeing it,
Yeah.
then I would go ahead and transfuse them until I get them hemodynamically stable, regardless of what their hemoglobin is.
So
those
being
are
that this
often-
is a 32-year-old female, otherwise pretty relatively healthy, you're not overly concerned as far as transfusion goes.
No, I would keep a close eye. I would probably have I would still kind of follow up, get a repeat CBC on her at some point, maybe a couple months later, and see what's going on, see if the iron's actually helping. I would actually keep a very, very close eye on her iron panel as well to see if her serum iron is starting to go up, to see if her ferritin's starting to improve as well. And I would also keep an eye on her reticulocyte count to see if that's starting to go up as well.
Okay. Sounds good to me. Pretty straight cut there. Let's move on to case 2.
Let's do it.
All right. So we have got iron deficiency anemia crossed off. Next one, here we go. We have a 58-year-old male with rheumatoid arthritis presenting with worsening fatigue and weakness over several months. We get some lab findings back, and they are as follows. Hemoglobin 10.2, MCV of 78, ferritin's high with a level of 300.
Okay.
Serum iron is low, TIBC low, and the transferrin saturation is low. Based upon the first case, we're going to kind of go through those same questions and just break it down.
Okay.
So the first question is, based on the findings of the iron panel, what suggests anemia of chronic disease over iron deficiency anemia, and what in the history would really support that?
This is awesome. So I think this is perfect because it sets us up just as we kind of left off with the last case, where what's the hemoglobin first? Is it less than the threshold of what we're looking at for our institution? In this case, it's a male less than 13. Yes, we have anemia. Next thing is the MCV. Is it less than 80? Yes, it is. So it's microcytic. Our 4 differentials are as follows: iron deficiency anemia, anemia of chronic disease, sideroblastic, and thalassemia. From there, look at the serum iron. Is it low, normal, or high? If it's low, then you get 2 differentials: anemia of chronic disease, iron deficiency anemia. In this case, it's low, so run those 2. Then you look at the ferritin. If the ferritin is low, it was iron deficiency. If the ferritin is high, it's more likely to lean to the anemia of chronic disease. In this case, we're kind of leaning to that.
Okay.
And the transferrin saturation and TIBC tend to be low. TIBC and the iron deficiency anemia tends to actually be on the higher side. So that would be one way that you could also differentiate. But the ferritin's a pretty good one. The only time I would say be careful with the ferritin is that patients can actually have iron deficiency anemia. And let's say, for whatever reason, they get sick. They get acutely ill. When you get acutely ill, ferritin is a acute phase reactant protein. And so whenever a patient's ill and they have systemic inflammation, their ferritin can go up. And so it can throw off your lab values. You have to be very, very careful. If a patient has iron deficiency anemia, they have a low iron, and then their ferritin tends to be normal or high. It doesn't necessarily exclude it.
Okay.
That's why you have to look at their TIBC and their transferrin saturation. If the transferrin saturation is low and the TIBC is going to be high, that leans more to the iron deficiency anemia. If the ferritin is high and the TIBC and the transferrin saturation are low, that leans to the anemia of chronic disease.
In which case, TIBC, transferrin saturation in this patient are both low.
Yeah. And the concept behind this is that because whenever you have inflammation going on, especially in anemia of chronic disease, this actually tends to downregulate the transferrin production. And so that's why the TIBC goes down in this patient as compared to the TIBC in the patient who has iron deficiency anemia. So I would say, based upon that low serum iron, the ferritin being high, and then on top of that, the TIBC being low, and on top of that, the history. So we need something that's what happens in anemia chronic disease as compared to iron deficiency. Iron deficiency is you don't have enough iron to take and actually make heme. So heme is made up of, when you think about hemoglobin, it's made up of globin, which is protein, and it's made up of heme. And heme is made up of iron, and then also some of the pigments that we need to make up that heme. And so I need to have iron plus the pigments to combine them to make my heme structure. And so if you have iron deficiency anemia, you don't have the iron component. If you have anemia of chronic disease, what happens is inflammation in things like rheumatoid arthritis or systemic lupus erythematosus or colorectal cancer or inflammatory bowel disease, those kinds of states, they cause systemic inflammation that tells the liver to increase the production of a protein called hepcidin. And hepcidin basically shuts down your macrophages from releasing iron, and it shuts down your GIT from absorbing iron. And so if you think about it, you have less iron in the bloodstream. It's not that you're not taking enough in or that you're losing it. It's just that you're not actually utilizing the iron that you need to make heme. So that's the big difference here. And that's what's kind of helping me is I see RA, and that's a really big trigger.
Being that, these are really systemic conditions, so you're getting a systemic response.
Yep, exactly.
All right.
Exactly. that's what I would say kind of triggers me to think that this is most likely anemia of chronic disease, is definitely the iron panel, and then in combination having that history that suggests an area of systemic inflammation.
So now that we've kind of hammered it down, we have anemia of chronic disease. What would be the treatment of choice in these patients? And are erythropoiesis stimulating agents ever indicated?
That's a good question. So, and again, I guess I
Yeah, I didn't write these questions.
pat myself.
Yeah. We want to have a good back and forth here, but like, unfortunately, I don't know too much about erythropoiesis stimulating agents.
Well, I think that question still is awesome because it kind of sets it up in a nice way, in the sense that when you think about anemia of chronic disease, it's the disease that's causing the anemia. So treating it with things like as you brought up, erythropoiesis stimulating agents like erythropoietin. Erythropoietin is good if a patient has anemia of like chronic kidney disease.
Okay.
Because in chronic kidney disease, there is inflammation, but what happens to these patients is that they shut down their kidneys from being able to produce EPO, and EPO stimulates the red bone marrow to make red blood cells. However, anemia of CKD fits more in the normocytic camp. It can exist in the microcytic kind of anemia, but it's not as common. It's much more common in the normocytic camp. Same thing for any other anemia of chronic disease. This is one of those weird ones where it can actually exist in both. It can be a microcytic and it can be a normocytic disease. But what I would say is we have to treat the underlying disease here. So oftentimes this anemia is not severe. It usually doesn't fall down like too low, like below 10. It usually stays above 10. So that's one of the big things that's actually helpful here. But if a patient has rheumatoid arthritis or SLE, corticosteroids and like a DMARD of sorts, maybe like, depending upon which type they have, mycophenolate or Tacro or hydroxychloroquine, whatever it may be, I need to give those combos to kind of suppress the inflammation. And that should, over time, help to treat the actual anemia itself. ESAs, as you said, we only really give them in patients who have anemia CKD and their hemoglobin drops to less than 10. That's when we would consider it, just to help to prevent them from getting frequent transfusions.
So we talked about it before in the first case, but same thing here with blood transfusions. We're not too concerned about this one because it's not below 7, correct?
Yep, exactly.
And then there's not really that, past medical history of some type of a coronary involvement.
Solid.
So we're not overly concerned.
Nope. I don't see any history here that suggests like CAD or any kind of acute hemodynamic instability or anything like that, or severe symptoms that make me want to trigger a transfusion for this patient.
Awesome. So like we talked about, just doing the supportive care and the medications we discussed.
Yep.
And should be all good.
And they should be okay.
Okay.
Should be okay.
All righty. Well, then there's case 2. Let's move on to case 3.
All right.
We have a younger patient. We have a 7-year-old boy, presents with jaundice, pallor, and fatigue. He has a history of anemia and regular blood transfusions since 6 months of age. That's very, very sad.
That's terrible.
So we get some lab findings back as follows. Hemoglobin is 6.2. MCV is 60. Serum iron is normal. Ferritin is elevated. TIBC is low. Transferrin saturation is normal. And we also do a peripheral blood smear, and we get back target cells and nucleated red blood cells.
Yep.
So based upon the findings of this iron panel, Zach, and the patient's presenting case, what would be the next test to confirm the diagnosis given suspicion based on history and the above iron panel? What are we thinking here?
All right. You guys are going to hate me, but again, I think it's really good to have a system. So look at the patient, hemoglobin. If it's a male, less than 13, female, less than 12, definitely below that for the hemoglobin threshold, anemia. MCV is significantly low.
Yeah.
I always tell from when in the past when we actually lectured on anemia, if the MCV is significantly low, like really low, and a patient has a family history or any kind of history of like needing blood transfusions or history of anemia, you really want to be thinking about thalassemia. All right.
And we already have that with this patient.
Yeah.
Unfortunately,
exactly.
has a history of anemia and repeated blood transfusions.
Yeah. So I'm starting to think that already. So I have a microcytosis. I got my 4 differentials: anemia, chronic disease, iron deficiency anemia, thalassemia, and sideroblastic. Next thing I look at is my iron panel. I like to know, is it low or is it normal or elevated? If it's low, iron deficiency anemia, chronic disease. If it's normal or elevated, it could be thalassemia or it could be sideroblastic anemia. That doesn't really help me anymore. And so looking at the ferritin's not going to be super helpful. Looking at the TIBC and the transferrin saturation is not going to be super helpful here. All I want to look at is the peripheral blood smear. What does that show? And target cells are actually interesting because it can suggest that this could be due to thalassemia. For me, it's the history that makes me more concerned, though. And so since they've had regular transfusions, they are young, they have a history of anemia, and they have a really, really low MCV with having these target cells and a normal, what I would say for the most part, is kind of a regularly normal iron panel or not remarkable, I would need a hemoglobin electrophoresis. The reason why is a hemoglobin electrophoresis will show me if I have any morphological changes in hemoglobin. So for example, when we talked about anemia chronic disease, it was you're absorbing iron, you have enough iron that you're actually getting in your body, you're not losing it, you're not having a problem with absorption or demand or anything like that. In this case, it's just that your body's not utilizing the iron that you need. Iron deficiency, you're just not getting enough iron in. And so you're not making heme. In thalassemia, you actually don't make the globin. And so the heme part's fine. The globin part that you need to combine with heme to make hemoglobin is absent or deficient. That's what I need to know. And so when I think about these, there's two different types of thalassemias. There's alpha thalassemia and there's beta thalassemia. Alpha thalassemia, you don't make the alpha globin chains. And beta thalassemia, you don't make the beta globin chains. So what I want to know is, if I get the hemoglobin electrophoresis, which one is it? So for example, let's say that I got the hemoglobin electrophoresis, and let's say that the patient had a elevated hemoglobin F, right? They had a elevated hemoglobin A2 and a absent hemoglobin A. And that's potential scenario that makes me think about beta thalassemia. The reason why is when you think about beta thalassemia and you think about all these different things I said, hemoglobin F, hemoglobin A2, and hemoglobin A, hemoglobin F is kind of alpha and then your gamma subunits, the globin chains, right? So there's no beta involved in that. So if you don't have beta, you're going to upregulate your actual gamma subunits. Hemoglobin A2 is going to be the delta subunits. So there's no beta in it. It's alpha and delta, 2 alpha, 2 delta. So if I don't have beta, guess what I'm going to do? I'm going to upregulate my amount of alpha and delta. Hemoglobin A, or A1, is alpha and beta.
Okay.
If I don't have beta, then what's going to happen? I'm not going to have any hemoglobin A1. So that's what happens in this scenario, is that you upregulate the other chains, the delta and the gamma, to compensate for the absence of the beta. So that's what I'd be looking at if it was a beta thalassemia in this particular scenario. If it was alpha thalassemia, funny enough, their hemoglobin electrophoresis tends to be kind of like somewhat normal. Their hemoglobin A is a little bit on the lower side, but they have this weird protein. It's called hemoglobin H. And that is usually a bunch of like alpha tetramers that kind of combine together and make this weird hemoglobin H structure. So sometimes if you see kind of a normal hemoglobin electrophoresis, you think alpha thalassemia, or if you see the hemoglobin H. If you see hemoglobin F increased, hemoglobin A2 increased, and a decrease in hemoglobin A1, you think beta thalassemia. So that's what I'm thinking here, is this patient has beta thalassemia. And I think because they're super symptomatic and having complications, it's beta thalassemia major. Because usually the other types where it's like minima or intermediate, those are usually not too bad. It's either asymptomatic or they have a trait, or it's like a very, very mild anemia. In this case, it's very severe. So I'm going to say this is beta thalassemia major or Cooley's anemia.
So with this type of patient and with this beta thalassemia major, there's some clinical features like hepatosplenomegaly, enlarged skull and face. Where does that come from? How do these clinical features really manifest?
Yeah, and so that's what you want to look for on your vignettes. And the reason why this is actually helpful is if you see this for beta thalassemia major, or if a patient has hemoglobin H disease or hydrops fetalis, which is the worst case for alpha thalassemia, what happens is that their bone marrow is doing the best it can to make red blood cells, but it's not doing a good enough job. And so what happens is you actually start tapping into other sources. So you actually tap into the liver and you tap into the spleen to actually help them upregulate red blood cells, because the liver and spleen, they do a small amount of hematopoiesis or erythropoiesis, the production of red blood cells. So what's going to happen is your bone marrow is not doing a good enough job. Liver and spleen kind of take over, and it's called extramedullary hematopoiesis. So they pump up more red blood cells. So unfortunately, they get a little bit bigger as a result of that. The enlarged skull and face is that the bone marrow is doing the best it can, but unfortunately, it's not doing a good enough job. So it actually starts expanding to try to do its best to make more red blood cells. So bone marrow expansion, in an effect to try to increase erythropoiesis, makes their face and parts of their skull and other parts of their, which we call a chipmunk facies, if you ever see it, really is what happens as a result of that. So extramedullary hematopoiesis, the liver and the spleen, making red blood cells in an attempt to help. That's what causes the hepatosplenomegaly. and then the bone marrow expansion in effect to increase erythropoiesis in the face and skull bones and things like that is the reason why they have that kind of like chipmunk facies look.
Why is the reticulocyte index elevated in beta thalassemia major compared to other microcytic anemias?
That is really helpful. And the reason why is whenever you look at the anemia, when you go through the algorithm, it's always helpful to say, okay, once I get to this kind of like patient who I think has microcytic anemia, most of the time you don't have to check a reticulocyte index because for the most part, reticulocyte index is a measure of how good of a job the bone marrow is doing to produce red blood cells. So microcytic anemia, pretty much all of them, they struggle to make red blood cells, except thalassemia. It does struggle to make red blood cells. The problem is that the red blood cells that they do make actually get kind of, they make these weird tetramers like I was talking about. So they make things called hemoglobin H and alpha thalassemia or hemoglobin H disease. And then they make also, so they make beta tetramers or alpha tetramers, and they lead to these inclusions. What happens is the spleen ends up seeing that, and then they see these like little weird inclusions in the red blood cells, and then they start chewing them up. And when they chew them up, what happens is you actually have what's called hemolysis. That hemolysis then tells the red bone marrow, hey, I'm chewing up red blood cells. I need you to pump out more. And so that's usually what happens is in hemolysis or blood loss, reticulocyte indexes go up. Thalassemia is a weird one, especially if you have beta thalassemia major or hemoglobin H disease. Those are the weird ones. You actually have hemolysis and your bone marrow struggling to produce normal size red blood cells. So they actually break down the red blood cells in the spleen because of those weird inclusions, the beta tetramers or the alpha tetramers. Or on top of that, they actually have a little bit of a struggle in making the proper size red blood cells. And so that's why usually the reticulocyte index is almost always low in any microcytic anemia. The only one where it'll be a little bit high is going to be the thalassemias.
All right. Let's move into the treatment now. So what would be in this patient, in this scenario, what's the treatment of choice with beta thalassemia major? And this is in both in terms of symptoms and potential treatment of the underlying cause.
Yeah, so first thing I would say is because these patients, if they have a reticulocyte index that's pretty high, that means that they're hemolyzing a lot of their red blood cells in their spleen. So you got to be careful with that. And so if I see a lot of let's say a patient has to get frequent transfusions, right? Yep. In this case, the patient has gotten transfusions, and we would have to continue that to make sure that the hemoglobin always stays above 7. But if they're having to repeatedly get lots and lots of transfusions because they're hemolyzing, the reticulocyte index is pretty high, I would do a splenectomy. That's one thing I would do is I would probably remove the spleen just to reduce the frequent anemia, the frequent hemolysis that may be going on. The other problem with this is that this is a genetic problem. There's no treatment that I could really give to this patient other than putting new stem cells into their bone marrow. So if I put new stem cells into their bone marrow, I could potentially help them to make the proper, like normal globin chains. So if I give them new stem cells that don't have these mutations that lead to the absent or faulty globin chains, that's the fix.
Okay.
So that's what I would do is I would say continue to give transfusions to keep the hemoglobin greater than 7. If they're having lots of hemolysis, so the retic index is going up, and they're having to get frequent transfusions because anemia is getting worse, cut the spleen out. And then on top of that, I would try and schedule them for a bone marrow transplant if I can find the proper way of them getting that done. That's the way I would do that. The only thing I would be careful with, and this is common with thalassemias and sideroblastic anemia, is sometimes they have to get frequent transfusions. If you give transfusions, you're giving blood, and that blood does unfortunately contain iron. Yeah. And if you give them too much of it because they're having to give them frequent transfusions, the iron levels will go up, and they can develop secondary hemochromatosis. They can develop diabetes mellitus. They can develop hyperpigmentation. They can develop restrictive cardiomyopathies. So a lot of problems with that. And so what I would do is I would give them a chelating agent. Deferoxamine is oftentimes the one that we like to see in the exams. So that's something I would do if they're having to get frequent transfusions. So transfuse if hemoglobin is less than 7. If they're needing frequent transfusions and their iron levels are going up and they're developing symptoms of hemochromatosis, add on chelation therapy. If the retic index is going up and they're still having frequent anemia with needs for transfusions, cut the spleen out and try your best to get them a bone marrow transplant. So that's what I would do for this one.
And being that this is a genetic condition, you said there's not like an actual treatment for that, but the bone marrow transplant, that could be curative.
Yeah, theoretically it should be curative.
Wow.
Yeah, that's always the goal.
That's amazing. Yeah,
that's always the goal.
All right. Well, there's that case. We're going to keep on moving on here then.
Yeah, and then funny enough, they try and do the transplants with siblings. So they try to see if they can get like a sibling to actually do
For the match.
Yeah, exactly.
Yeah.
So that's oftentimes what they'll try to do. It's just mattering of hopefully there is a match there.
It really is amazing. If you can hear that, that's
I know,
freaking
especially
awesome.
in these young patients.
Yeah,
It's sad.
seriously. That's at least, gives you a little bit of hope.
Yep.
Cool. All right. Last case then. Here we go. We only got one left, so you could probably guess what it is. We have a 28-year-old male, presents with fatigue and pale skin. He has a family history of anemia. We get some lab findings back as follows. Hemoglobin 10, MCV 75, serum iron high, ferritin high, TIBC is low, transferrin saturation is high, and then we do a peripheral blood smear like before, and we get back basophilic stippling.
Nice.
So, Zach, based upon these findings of the iron panel, what would be the next test to confirm the diagnosis, which we're left with sideroblastic anemia.
Yeah.
So what would be that next test to really say, oh, okay, we're left with sideroblastic anemia, and if you got to be repetitious here, hey, practice makes perfect.
Yeah, exactly. So start off, hemoglobin, male, less than 13. We got anemia. Next thing, MCV. Is it less than 80? Yes, it is. So we got microcytic anemia. If I wanted to, I could check a reticulocyte index. If it was pretty high, I could be thinking about thalassemia. I don't have that here. But if I did, that would maybe think about potentially thalassemia. Next thing is the iron panel. Is it low? If it was low, it'd be anemia chronic disease or it'd be iron deficiency anemia. If it's normal or high, it could be thalassemia or it could be sideroblastic anemia. So then the rest of the other parts don't really help me for the iron panel. Next thing is the peripheral blood smear, basophilic stippling, and Pappenheimer bodies. If you ever see that on the vignette, always think sideroblastic anemia. So basophilic stippling or Pappenheimer bodies, think sideroblastic anemia. I look at the history, and this is where you could get tripped up. Family history of anemia. Okay, well, Zach, you said thalassemia, you can have a family history. So sideroblastic, you can as well? Yes. So you can have an X-linked defect. And so in this potential scenario, you have a defect in one of the chromosomes that helps with the production of an enzyme called ALA synthase, which actually helps to synthesize heme. And so that is a possibility. What you would also see with sideroblastic anemia, just so you know for the vignettes, is that you could see a patient who's consuming a lot of alcohol. That can also cause sideroblastic anemia. Another one would be a patient who is taking, always look for this one, a patient who has tuberculosis and they're taking isoniazid. That's another one that we can see a lot. Myelodysplastic syndrome, which is kind of like a prelude to having cancer, like AML, that can also lead to this as well. And so we can see this with other drugs as well, like carbamazepine. But I'd say the big things that you would see this with is alcohol use. You'd see this potentially with a patient who's taking drugs for like tuberculosis, like isoniazid, and then a patient with a family history. It's an X-linked defect. So when I see basophilic stippling, that really makes me start to think about sideroblastic anemia, right? Especially if I even saw Pappenheimer bodies. So what I would do is I would say, okay, I'm thinking this is sideroblastic. How do I confirm? The only way to confirm it really is a bone marrow biopsy.
Oh, wow.
I would have to aspirate some of the components of their bone marrow and then look for special types of cells. What happens in sideroblastic anemia is their enzymatic pathway to make heme is all jacked up. So either they're taking alcohol or they're taking drugs which are disrupting those enzymes, or you have a genetic defect where you don't have the enzymes to synthesize heme. What happens is if you can't synthesize heme, you can't incorporate the iron into the heme to make the components of your hemoglobin. And so iron builds up, especially kind of in the mitochondria and around the nucleus, and it makes a ring. And so when you see it, it actually looks like what we call ringed sideroblast when you put it under a Prussian blue stain. And so if I did a bone marrow biopsy, I aspirated it, put on a Prussian blue stain, and I saw ringed sideroblast, boom, the diagnosis of sideroblastic anemia is done. If I was at all concerned that this could be thalassemia, I could also get a hemoglobin electrophoresis too, just to confirm and rule out thalassemia if I have any doubt. But I think the fact that they have a family history without the need for frequent transfusions, it makes me think that it's less likely thalassemia. The MCV, it's not super, super low. It makes me think about less likely it's thalassemia, but it could be more of the intermediate or the minor thalassemias. So I would still consider potentially getting a hemoglobin electrophoresis to rule out any abnormalities there. But I would also get a bone marrow biopsy to confirm, is there ring sideroblast that shows me sideroblastic anemia?
And you did say that sideroblastic anemia out of all of the microcytics is the most rare.
I would say that is probably going to be the least likely.
Okay.
Yeah, it's one of those ones where if it's genetic especially, that's going to be least likely. And I'd say you can see this with alcohol use, but I'd say alcohol use actually is more likely, funny enough, to cause macrocytic anemia. So you can see microcytic anemia and macrocytic anemia with alcohol use. Myelodysplastic syndrome, again, I'd say it's not as common. And then tuberculosis, not everybody's running around with tuberculosis around the world getting treated for that. So you can see it, but I'd say out of all of these, it's probably the least likely one.
So as a quick recap, just so I got this, we know that the most common genetic cause, X-linked sideroblastic anemia.
Yep.
Acquired causes being alcoholism, lead poisoning, and certain medications like if you TB, isoniazid.
Yep. That's another really good one too is lead poisoning. So sometimes lead poisoning is clumped in with sideroblastic anemia. Some clinicians hate that. Some people like to consider it as its own separate thing.
Oh, okay.
So lead poisoning, there is like a weird presentation for these patients. And you think about this, usually a child who comes in and they have like lead lines. So they have like these dark blue lines on their gums. They have encephalopathy, so they're confused, they're agitated, they're having behavioral changes. And then the other thing is that they're exhibiting anemia, and then they have drop foot.
Wow.
So if I have those kinds of things in combination with basophilic stippling and a kid who maybe was eating like the older like lead chip paint and stuff like that, I would check a lead level too. So that is something that you can see where if you see basophilic stippling and a child who comes in with lead lines, we call Burton's lines, you see encephalopathy, you see potentially some abdominal pain and some anemia. On top of that, they have drop foot. I would check a lead level just to make sure that there is no lead poisoning.
So not really necessary in this patient, but again, if the clinical picture suggests it, you would, of course, order that test.
Exactly.
Okay. Awesome.
And you can remember that lead poisoning with the mnemonic lead.
Oh, no kidding.
Yeah. Lead lines, encephalopathy, abdominal pain, and then drop foot. So if you see any of those in a kid who just ate some lead chip paint, then go ahead and check that lead level.
It's good when it works out like that.
Yeah, exactly.
What's the treatment of choice for patients with sideroblastic anemia? What's the go-to?
So again, oftentimes for most of them, except the ones who are genetic or they have a acquired B6 deficiency. So most of the time, the issue is if it's an X-linked problem, you don't have the active enzyme ALA synthase. Or if it's other things like you have tuberculosis and you're taking isoniazid, that can actually cause B6 deficiency. That also makes the ALA synthase enzyme not work and you can't make heme. So in only those two scenarios, you actually give them B6.
Okay.
And that should fix it. So if they have a genetic component here, like a family history, I would treat them with B6. Or if they had taken isoniazid, I give them B6 to also treat this as well. But all the other stuff, you got to treat the underlying cause. So if it's alcohol use, you have to treat them by alcohol cessation. If it's another drug like carbamazepine or some type of other medication, I'd probably have to discontinue those or switch to an alternative. And if it's a patient who has lead poisoning, we'd have to give them some type of lead chelating agent like dimercaprol or EDTA is another one that we can do to bind up the lead so that it's not actually impeding this heme synthesis.
What about TB? Like, are you just going to say, "Oh, sorry, you're stuck with TB now"?
So I would keep treating them. I would keep treating them with the isoniazid, but I would just add on the B6.
Gotcha.
It's going to at least help to mitigate because isoniazid does unfortunately cause a B6 deficiency. So if I can at least give them back the B6, I can help to mitigate
you can
some
compensate
of that.
for that.
Yep, I definitely can't stop that TB
Very cool.
medication if it's necessary. So I'll just give them the pyridoxine to help to treat that.
Okay. Now, unlike thalassemia, these patients are at a very, more of a greater risk for hemochromatosis. Mm-hmm. Why is that?
It's weird because you think, oh, Zach, these patients aren't getting a lot of blood. They can get blood transfusions, but they're not getting it as frequently as a patient with thalassemia. The kind of the weird reason behind this one is that they basically shut down where you combine the iron into like the components of the heme. So we call this protoporphyrin. So where iron is combining with protoporphyrin to make heme, we're shutting that down. And so the iron actually tends to build up in the cells and it can spew out of these like cells into the bloodstream.
Okay.
And then what happens is these patients can unfortunately get hemochromatosis because of that. And so it's just because of the poor like utilization of the iron. It's not getting utilized in the proper way in these bone marrow cells that it can cause this. Yeah. I'd say both of them pretty high risk, but for some reason, sideroblastic anemia, they just don't utilize the iron, and so it sits in there, and because of that, it can spew out of those cells in the bone marrow into the bloodstream, and it can cause that hemochromatosis.
Wow. No, it's pretty interesting.
So same thing with this one. In these patients, I'd be very careful, especially if they're getting transfusions, and I put them on deferoxamine, just as I would put on a patient who has thalassemia, I give them deferoxamine.
All right. Well, there you have it. That is the podcast episode on microcytic anemia. We're going to be moving into the next part of our trilogy here for normocytic anemia, which will be a beast.
That's going to be the worst one. It's going to be a monster.
It's going to be a lot of fun.
Yeah, it will be really cool because I think that's the one that oftentimes people see and they're like,
Yeah.
oh my gosh, there's like so many enzyme deficiencies and structural membrane defect and all.
There's just so many of them.
It just goes ham bone. But I do think after we target it in a very systematic way, it'll become a little bit easier.
Well, hey, it's better than combining all three of these together.
Yeah, we'd be here all day.
We might be here for a little while. Well, all right, awesome. So, well, thank you for that, Zach. That was super, super informative. That was awesome.
Yeah, man. Thank you guys so much for listening to the podcast. I really hope that you guys are enjoying these. I hope that they make sense and they help out a lot. We seriously love making them, and I hope that you guys enjoy listening to them. So I love you guys. Thank you guys. And as always, until next time.